Good afternoon, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today I'm joined by Dr. Kim Pruitt.
Hi, Chief.
And also Lieutenant Daniel Murphy.
Hi, how's it going?
Thanks for joining us today to come talk about your case. So this case is going to be regarding a head trauma call that you were on in charge of Rescue 1. So Rescue 1 was dispatched to a 17 Delta, and it sounds like the dispatch was a 22-year-old male who fell from a significant height. So talk us through what you're thinking about when you're on the way to that call.
Well, we were familiar with the bar. It said in the notes that it was canvas, so immediately I thought, man, I hope someone didn't fall off that balcony. But as we showed up, of course, that's exactly what happened. So immediately we thought, okay, we're going to expose, we're going to assess for head trauma. As we pulled up on scene, I could see a bystander's kneeling down next to the patient. And we exited the rescue and made contact, and the bystander happened to be a physician. So he kind of gave me a rundown, a quick patient status report, and informed me that he did have some crepitus and bleeding from the back of the head. So I fell down and took a look, and I confirmed there was crepitus. So I just asked my pipeman, okay, let's expose him. I'm going to go get an IV set ready, and we'll load him up right away. So I think our on-scene time was less than 3 minutes.
That's great.
So we got him in the back of the truck, and when they pulled him in, I was just, like I said, trying to get that IV set ready. So it was kind of hard because I was the only medic on scene. So trying to not only assess the patient for life threats, but also manage the scene and manage everyone there. I took most of the engine crew with me. Luckily, I had some intermediates there that I asked them to start a line as I started to assess airway because he was trismus at the time. Thank God that he was breathing okay through his teeth and he had a patent airway. So I didn't really have to do much with that, but he was slightly combative. So I gave him 5 Versed because, again, he was combative. I just needed to kind of take that edge off so he would stop fighting us. After doing all that, I remember, okay, radio report, we're less than 3 minutes from the hospital, so tried to get the radio report done. As soon as I finished that, I was able to establish a line because they had missed the first time on the left AC, so I was able to start one on the right AC, and right before we pulled in, they were able to get the right AC established. Again, given that radio report was kind of difficult because we're so close to the hospital, so much trying to get done. So because of the proximity to the hospital and how fast the transport was, we didn't really get a set of vitals. We weren't able to do much in the way of, I guess, any other interventions.
Yeah. So your rapid trauma assessment included just you get there, you realize what you have, you stop the bleeding as best you can, manage their ABCs, and then you load and go and try to get the C-spine controlled. That's pretty much the only things you can do in that short amount of time, yeah?
Yeah, exactly. So after I was able to get the radio report, I focused again back on his head, looking for any other signs of trauma, which we were able to establish that he did have deformity to the C-spine area. I think we were attempting to get a seat collar on him before we moved him. I'm not too sure if we got it on before we got in the truck or after, but we were able to get that done. And then once we got to the hospital, we just kind of gave the report in the ER and tried to explain to them the best we could, like, hey, I'm sorry for the lack of interventions or anything else, but we were right here, and it was just kind of understanding that there's not much we're going to be able to do on scene. Yeah,
and you talked about being the only medic on scene. My assumption is that day you were operating as a non-preferred rescue model, so you were the officer with a BLS or ILS driver?
Yes.
Okay.
Yeah, so again, luckily we did have an intermediate. I was able to start a line on the other side, but it was definitely a challenge, I would say. I think that kind of factored into my decision of let's just go, because we didn't have any other hands to do IOs or anything like that. So, and then I, again, realizing he was trismus, immediately I thought, well, I might have to crack this guy.
Sure.
So I said, all right, let's get him in the truck, because I don't want to crack him here on the sidewalk, and I want the need for us to get moving is pretty evident. Like, we need to get going now.
And you talked about the initial contact you made was with a physician who identified himself as such and kind of gave you a rundown. We have that happen a lot where we run with other medical personnel, whether it be nurses, physicians, other EMTs. Tell me how you navigated that and what your thoughts were and kind of your interaction. Did you feel like they were wanting to overtake the care of that patient, or were they just helping? And then how do you navigate that when you're on a call?
So, yeah, like you said, we deal with it quite often, actually, and a lot of times it can be a bit of a handful. Try not to take credit from any of those people, but when we're on scene, it definitely becomes an issue when they're trying to run the call for you. But luckily in this case, he was really helpful. He just kind of gave me the rundown and then got out of our way, which was nice. But that definitely, when I saw him on scene, he told me a physician, that definitely keyed up in my mind, like, oh boy, here we go, you know. But luckily, no, he was really, really helpful in the fact he just gave us a rundown and got out of our way. We were able to load him up and get moving right away. I would say try and be cordial with all these people and just say, you know, thank you for the help and I'll take it from here or whatever. If all else fails, I mean, it's your scene. You got to tell them, all right, dude, you need to step away.
Right. And we know we talk about it pretty regularly with the doc is like we appreciate everybody's help and they're stepping up if they're looking to help. But if it starts to become a hindrance, then we have that in guideline. It's written that if you want to take over care, you can show us your license and we'll step back. But typically that's not what they want to do. They kind of want to just help and help direct. But we know, like Doc always mentions, we don't know what types of physicians or nurses these might be. And ultimately we are the experts when it comes to emergency response. We operate under those guidelines. So I think that's probably the best way, is the way that you talked about, is try to remain cordial, be friendly, be respectful. But ultimately it is our scene and we have to take over that care.
Yeah, exactly. And it does become a problem when they are pretty much like they try and push it on you, and they try and make you feel like, well, you're not a higher licensure level, so you're going to listen to what I have to say. And that's when I said, like, at that point, if it's becoming an issue, that's when you just ask them to leave the scene. And at the end of the day, it is your scene, and you take command of it and run it the way you need to. But also, you know, if they are having some value information, don't just disregard it as well. Like for me, it was nice. He gave me a quick status report, informed me of the crepitus, informed me of his fractures to both forearms, and then stepped away. And that was really nice. So,
yeah, you did a great job of navigating that. We talked about super quick on scene. You pretty much loaded, packaged up. It was time to go. You were kind of thinking about that trismus and how you were going to navigate that, whether you're going to have to crike or not. For that short transport time, did you find that BLS measures were enough to kind of keep him going? You didn't have to go down the road to
yeah, definitely. That was probably my determining factor, minus, and then as well as him breathing fine. He was able to move plenty of air through his teeth. So both those things that, okay, I don't need to go down that route. I just get him transported, because ultimately we can't do anything for this guy. He's, you know, definitive care is going to be at the hospital. So.
Right. You also got the line. You said you did have help getting the line, so we started the fluids.
Yeah, like I said, and that was a huge help. Another point I want to talk about is recognizing our intermediates. I think that would be a huge asset to us, because, I mean, I've used several intermediates on calls, especially in that situation where I had a BLS driver, but one of the people on the engine was ILS. I mean, I think we've already started with ILS people on some of the medic units, but expanding that to where preferred staffing, maybe if we can find an ILS person to take that position over a BLS person, would be so helpful. Because a lot of times when I'm the only medic on the truck, all I need is someone to start a line and push meds. That's all I need. And trying to do everything as a sole medic on a truck can be very challenging. Especially like you said, when you're trying to establish airway, when you're trying to get IVs, when you're trying to assess other injuries and do a radio report. And when you're in that close proximity to a hospital, it's definitely challenging. So,
and it's absolutely our goal. I think we're looking at different options as far as intermediate school. We've talked to UNM already, so we're kind of looking at the staffing model over the summer, and hopefully by early next year is something we can implement, because I agree it's difficult to get a lot of people through paramedic school, but if we can get more people trained at the intermediate level, then overall it's going to help across the board. So it's great.
Yeah.
Doc, I'll kick it over to you. We talked about he did a great job trying to prevent the hypoxia by doing the BLS measures for the airway. He started a line which was treating the hypotension. Hopefully, why are those the best things that we can do in cases of head trauma?
So there's really good evidence. I think you did an excellent job all the way around. You quickly recognized the severity of this patient, that he ultimately needed the hospital, quick ABCs. The best evidence in very devastating head injuries shows that if we can, in the first couple of minutes when we get there, preventing hypoxia, preventing hypotension, those are the best two measures that we can do to prevent further ongoing brain injury and save those neurons that the patient still has. And so you quickly jumped on those aspects of his care. And then in addition to the other thing I think that may go unnoticed, but is also really helping out the hospital situation that you did in your quick 6 minutes in that patient encounter, is the sedation. It's not infrequent that patients with any level of head injury, the first thing to go is that frontal lobe, and they get a little combative. And taking time to address that, especially on these serious ones where it's interfering with patient care and the things that we know are most important for them, proceeding with chemical sedation, knowing you're going to have to pay, again, close attention to your airway, but getting that patient in a cooperative state where you can actually provide the care and help get them to where they need to go. It's actually helping the hospital out too, so he's calm when he gets there.
Yeah, he definitely, and I just gave him 5 just to take the edge off, which was plenty for us. I was hoping I wouldn't have to give him any more, which that's how it worked out, thank God. But yeah, I definitely agree. I mean, a calm patient is so much easier to work on instead of fighting someone. I would say anyone else in the situation, like, don't be timid. You know, if it's calling for sedation, then give it. I think it's very easy to defend that when you have a combative patient to any degree.
And especially, you know, with a potential C-spine injury as well, with them thrashing around and moving that head and that neck, like it's in the long run, this is the best thing you can do for them and for the safety of your providers as well, to proceed with their care.
And you did see that difference, right? As soon as you gave that 5, even though it was a short transport time, you start to see him relax a little bit, and you're able to treat him safely. And
exactly. And he wasn't combative to the point where he was trying to hit people. He just wouldn't stop moving around, which as soon, you know, a couple of seconds or a couple minutes after we gave versed, he just kind of laid there and calmed down and made our job a whole lot easier. And I definitely think my crew, being as competent as they were, helps a lot too. I would say, I know at ones we try and do some training every cycle, something. I think that helps the basics just stay sharp on what they're doing. So I'd recommend that for every station out there. Like, take the time as the officer, or even assign it to your driver. Do something, whether it be head trauma or airway. Pediatrics is something we don't do very often. So we definitely, one of the big ones I like to hit when we have new people is a Bureautrol, learning what it is, how it works. Because at the end of the day, that's our job, right? Like, we have to be competent in what we're doing. And I definitely showed on that call. It was very smooth. It was very quick transport, which ultimately for this individual, that was what was required. I mean, we could sit there and do all this other stuff on scene, but ultimately he needed the hospital.
Yep.
So.
That's a fantastic job. Well, that's thank you again for coming out and discussing the case. Thank you, Doc, for highlighting some of the clinical side of things. I really appreciate it. That's it. That's it for today's podcast. But if anybody has any other case studies that they want to bring forward, use our SharePoint tab or reach out to your 7-8. Until then, we'll see you next time. Thank you both.
Thank you.